Thank you everyone for joining us again on Thursday. This is DMC Medical Group Heart to Heart webinar series. We come to you every last Thursday of the month, talking about heart-related problems in the community, as well we see as in practitioner and cardiovascular systems. I'm really privileged to have our cardiovascular service line, Dr. Kenton Zer. He is the director of this series, and he's the co-host of all these sessions. Dr. Kenton Zer, he's our director of cardiovascular service line at the Detroit Medical Center, and he's a professor of medicine at Wayne State University. His background and specialty is cardiovascular surgery, valves, as well as bypass surgery. With that, I would like to introduce our guest speaker, Dr. Zahar. Please go ahead.
Thank you, Chadi. It's a great pleasure to be a part of this seminar series, and it's also with great pleasure that I introduce Kaushik Mandel today to be the lead speaker. Dr. Mandel is well known to me, as we spent 5 years together as colleagues at the Johns Hopkins Hospital, and then when I was fortunate enough to have moved to Detroit, Dr. Kaushik also came, and he is the director of the cardiovascular service line at Sinai Grace Hospital, which you saw a brief clip of in that introduction. We're very pleased to I should mention that his specific area of interest is minimally invasive valve surgery. Dr. Kaushik actually did many years of training. He trained in England initially, then trained again at the Johns Hopkins Hospital, and then again took a fellowship in robotic valve surgery with one of the lead people in the Carolinas. And we're very pleased to have Dr. Kaushik speak with us today.
Thank you for that kind introduction, Dr. Zair. Thank you, Dr. Alreyes and Elise, for this kind opportunity. So the remit of my talk, as asked by the seminar group, was current management for aortic valve stenosis, and I was asked to bring up the current role for surgical aortic valve replacement. I have included two specific subgroups, low and intermediate risk groups. The technology for transcatheter aortic valve replacement initially started off being trialed in extreme surgical risk category and high risk surgical category. It was a great boon. The technology took off, it demonstrated its safety and efficacy, and clearly in that particular subset of patients, it was superior to surgery and definitely way better than what medical management had to offer. Once the technology took foothold and established its safety and efficacy, partly driven by industry, the indication creep started to happen. And the next set of trials examining the role of transcatheter aortic valve replacement technology in the intermediate risk groups, STS risk category 4 to 8%, and finally to its latest trial iteration of low risk surgical patients, STS risk up to 4%. These trials happened, and I'll briefly run through what the trials show and where does surgical aortic valve replacement currently holds right now, and would be very interested in having Dr. Zair's and Dr. Alreyes' take on this. Dr. Zair is a very experienced aortic surgeon, given his extensive published experience coming all the way from his tenure at Mayo Clinic, and Dr. Alreyes' experience as a structural cardiologist within the DMC Medical Group. I do not have any financial disclosures. My only conflict of interest is I'm a surgeon. I think the best paper that, as I was preparing this talk, that I came across was this recently published meta-analysis under the aegis of the International Society of Minimally Invasive Cardiothoracic Surgeons. It was published in the Societal Journal Innovations. But look at the authorship group. Who's who, the thought leaders in the field of structural heart cardiology, spanning the entire spectrum of respected surgeons who are bold enough to speak their mind, and cardiologists who understand and take surgeons without feeling slighted when they are being commented upon. So I think it's a very credible group. It has taken all the published literature, finally came down to 21 studies, including randomized controlled trials and propensity matched retrospective case series comparing patients in the low and the intermediate risk group. As far as the high risk and the extreme risk group patients are concerned, it's a given deal. TAVR is the way to go for helping those patients out when appropriate. So my entire talk will primarily focus on patients in the low and the intermediate risk category. And briefly, the conclusion for this meta-analysis, comprising of those 21 studies, says comparing TAVR and surgical AVR in low-risk patients, early mortality and stroke were lower in TAVR, but did not differ at 1 year. There was no difference in mortality and stroke in the intermediate risk patients. The multidisciplinary heart team must consider individual patient characteristics and preferences when recommending TAVR versus sAVR. The decision must consider the long-term management of each patient with aortic valve disease. Just a quick divergence. The randomized controlled trials comparing TAVR versus sAVR. So intermediate risk category, the TAVR is non-inferior. Both treatments are exactly comparable when you look at mortality, stroke, major comorbidities, and outcomes. In the low-risk trial, the Medtronic core valve platform came out non-inferior, but the Edwards SAPIEN 3 platform in their 1-year pivotal trial that was reported in the New England Journal of Medicine reported that TAVR was actually superior to surgical AVR, and their composite outcome was death, stroke, and rehospitalization. My next set of slides are from the American College of Cardiology presentation by Dr. Michael Mack and Marty Leon, who were the lead national PIs for the PARTNER 3 trial, which is the SAPIEN 3 low-risk trial. And I want you to take through the 2-year outcomes. 1-year outcome was reported as TAVR being superior. This is the only low-risk trial that reports superiority. So briefly, this is the trial design. STS, low risk defined as patients with less than 4% risk, 1-to-1 randomization to either TAVR using the SAPIEN 3 balloon expandable platform or surgery with bioprosthetic valves, follow-up 30, 60, 6 months, and then annually through 10 years. And as I said, primary endpoint is composite all-cause mortality, stroke, and rehospitalization. Inclusion criteria, as you can briefly see, that they were indeed low-risk patients. Please mind the exclusion criteria. Patients with extremely large aortic annulus were excluded. Patients with bicuspid valves were excluded. Those with concomitant aortic regurgitation, those with severe LV dysfunction, severe calcification of the LVOT, aortic valve complex, complex access vascular anatomy precluding safe femoral access. The trial was only superior as long as the TAVR could be done via femoral access. And then patients with associated complex coronary artery disease. And the reason I'm emphasizing these exclusion criteria because in the real life, we do not see patients only with isolated aortic valve stenoses. That is a small subset. A lot of patients present with a bunch of other anatomical considerations, and that'll be the topic of focus later on in the talk. So please do keep these exclusion criteria in mind when I go through recounting, trying to establish where surgical AVR fits in currently. Pretty good follow-up. 96.5% patients were available for endpoint analysis at 2 years. So on primary composite endpoint analysis, even at 2 years, death, stroke, rehospitalization, TAVR still remained superior with the Edwards SAPIEN 3 platform transfemoral access. However, if you delve a bit deeper onto the data, the death, which was significantly more in the surgical AVR group at 1 year, by 2 years, that becomes statistically non-significant. Both the treatment therapies are approaching similarity. Stroke, 1 year, TAVR was doing better than surgery. By 2 years, they're approaching no statistical difference. So the 2-year composite endpoint superiority of TAVR with the SAPIEN 3 platform is primarily driven by a significantly higher rehospitalization amongst the surgically operated patients. The causes for rehospitalization, congestive heart failure still remains the predominant cause. Stroke, again, something in the later slides you will see. I want you to focus on the 20% risk of stroke with valve thrombosis, almost exclusively noted in the TAVR group. No patient in the surgical AVR group had that issue. Syncope, bacteremia, more in the TAVR group, and permanent pacemaker implantation more in the surgical AVR group. Valve thrombosis, this was a predetermined analysis built into the trial design using CT and clinical criteria. It was defined as either an absolute mean gradient greater than 20 millimeters of mercury in a newly implanted valve, or a change in gradient from the prior measurement by more than 10 millimeters of mercury. And as you see that with this definition, the valve thrombosis with the newly implanted aortic valves occurred significantly more in the TAVR group.
Dr. Mendel, just go back to that slide for a second. I want to ask you and Dr. Zera a question.
Yeah.
Now, gradient is a prognostic, an increase in gradient is a prognostic indicator for the valve lifetime.
Yes.
Why do you think, just for the audience, primary care, cardiologists, and people who really refer patients for these procedures, why surgery has 0 at 2 years and TAVR has almost half in the mild range?
Okay.
Well, I think that's an easy question to answer, Chadi, because the calcium in the valve is not being removed. And so you're limited by how much you can expand your TAVR valve within that calcified construct. And so one of the advantages of surgery is that we trim all of the debris and calcified valve away, which allows you to get a maximum orifice to insert your valve. And so you're starting behind the 8 ball with a TAVR in that situation, which also brings to the other question which is a more sophisticated question, is what is the feasibility then of a valve-in-valve therapy when the TAVR valve wears out in a young patient?
Right.
And I think this is where we're going to start to see that that's not going to be a panacea for a failed TAVR valve, is just to plop another valve inside, because now we're going to start getting into problems like patient prosthetic mismatch and creating aortic stenosis.
So you are not removing, you are just putting layer over layer.
Sure.
Inside
the biggest thing is the fact that the nicest thing about a surgical replacement is you clean that annulus. We always dictate on our op notes, the annulus was debrided cleanly. you know, and then you put your stitches in good tissues. And so there's several problems you don't see with surgery that you're going to see more and more, or that you see more with TAVRs, like paravalvular leak, and like that you don't get the biggest size valve that you could normally get with a surgical replacement.
Yeah.
Yep. Thank you.
And if I may just add one more thought to that, is I also think that because you have the calcified rigid leaflets of the native valve still in process, and the TAVR valve leaflets sit within that, it creates a lot of turbulence, and probably some of the thrombosis that is being observed clinically in the explanted valves and what's being observed on the CT is because of the turbulence and stasis that is happening in these nooks and crannies. Whereas in the surgical valve, you've cut the calcified valve out and it's just the bioprosthetic material. But as far as the eddy currents that wash the sinuses of Valsalva are pretty much back to normal. So that could be also another factor that plays in, explaining the higher rates of thrombosis that are being observed and reported with the TAVR technology. And look at these observed valve thrombosis. Each of them were correlated with a clinical stroke or syncopal event, which is worrying. And when this was attempted to be mitigated by increasing the anticoagulation as adding NOACs or Coumadin based on there were patients who developed subdural hematomas. There were patients who developed periorbital ecchymosis. So it's not a carefree ride that you think, okay, let's put it in TAVR, we'll anticoagulate and things will be okay. In high-risk patients becomes easy to justify, but low-risk or intermediate risks patients in the realm of 4, 5, 6% STS mortality, it again becomes a difficult justification. And PVL rates, mild to moderate PVLs still significantly happen more commonly with TAVR. We certainly know that trace PVLs do not cause any significant untoward impact on the long-term outcome, but and moderate does impact on the long-term survival, especially with regards to heart failure related events. Mild is still, the jury is still out, and we are actively watching the data in terms of where and how these patients behave. So then so with those factors in mind, so essentially I would make a case that the PARTNER 3 trial in the low risk cohort, which had reported 1-year outcomes being clearly superior, death, stroke, rehospitalization over sAVR, when you look at the 2-year outcome, the difference in death and stroke is already gone. Rehospitalization still remains significantly more in the sAVR group. It'll be interesting to see what the 5-year and the 10-year publication tells us about these outcomes and outcomes related to valve thrombosis, structural deterioration, and other issues. Now, this table has been taken from the meta-analysis that I had shown in my first slide, and I think it really drills down and brings each of these anatomical constructs. So I'll take point by point. So the first scenario is intermediate risk patients, STS predicted mortality less than 5% with bioprosthesis. It says reasonable to have either TAVR or sAVR. And I think, honestly, with the patient in front, with all full disclosures, the current best available evidence, it's a fair thing. However, mind you, in the recently concluded MST-CVS meeting, they shared their experience with redo TAVR patients. So these were, mind you, obviously, none of the low-risk patients yet have come down for redo, but Dr. Zaire has done a few, I think in his experience, around 4 or 5 patients of high risk, intermediate and high risk patients. at Hopkins, and the Michigan group, along with the Columbia group, had pooled in a total of about 30 or 40 patients, again, intermediate to high-risk patients who developed endocarditis, thrombosis, recurrent stenosis, and were referred back for surgery. The surgical AVR in these patients who had primary TAVR for native aortic stenosis, the mortality was 12%. Compare that to the STS national mortality for AVR is around 2 to 3% at the most. And that is because you're needing to, when you explant these TAVRs, they don't come out, they're integrated into the aortic root. You're needing to do complex root reconstructions, you need to do a full root replacement. So essentially, you are putting that patient at risk for a much higher risk procedure. And again, these are the nuances that a structural team with a surgeon and a structural cardiologist together should bring out to the patient, and then let the patient make the decision what they think is best for them. Patients with STS greater than 5%, the consensus from the committee was should have TAVR unless there are anatomical contraindications. And down below, the anatomical contraindications are coming. Low-risk patients, patients without LVOT calcification, noted on the screening CT, or aortopathy, reasonable to have TAVR or sAVR as determined by the team. But if you have severe LVOT calcification, risk of coronary artery obstruction, patients should not have TAVR, they should have surgical aortic valve replacement. Patients with bicuspid aortic valves, those with intermediate, those who are in the intermediate to high risk categories, STS greater than 5%, should have TAVR, but also reasonable to have sAVR, especially if these, based on the Sievers classification and how these valves will sit and what is the anticipated paravalvular leak that is suspected based on the geometry of the bicuspid valve. On the other hand, if patients have high calcium burden in their bicuspid valves, the aortic root or the ascending aorta is greater than 4.5 centimeters, and they're otherwise low risk, as in less than 5% predicted mortality, it would behoove for them to have TAVR. They should have surgical aortic valve replacement with concomitant solution for their aortic aneurysm. Low to intermediate risk patients, no aortopathy, TAVR. But again, bicuspid valve, the way the valve sits in, I don't know how the patients would react that if it's a 55 years old patient. We know that bicuspid aortic valve patients present on the order of about 10 years earlier with their stenosis compared to the tricuspid valve stenotic patients. You're recommending a tissue valve TAVR in that patient, and then they're coming in for a sAVR later. Their operative risk is 12%. If that information is shared with the patient, I don't know how they're going to react. We owe that we do share that information with the patient. Yeah, and probably in my mind, I would set the patient do a surgical AVR now with a larger prosthesis, larger than a 23 millimeter valve, and then set the patient up for a TAVR maybe at the later date, if need be, if that's how we're going to look at. Patients with aortic aneurysms, if the patients have low risk, less than 5%, they should not have TAVR. Intermediate to high risk patients, you want to ignore the aortic aneurysm. I had a patient a few days ago, 85, frail, aortic stenosis and an aneurysm at about 4.8 centimeters, fair enough. You could, as long as those things are laid out on the table, probably it's reasonable to ignore the aneurysm and address the AS with TAVR. Those with coronary artery disease, the consensus committee just relied on syntax score, I would like to add concomitant diabetes, because you don't want to be doing PCI to the LAD and circ in a diabetic low risk patient just because the syntax score is less. The prognostication should be put in the correct context. Patients with concomitant atrial fibrillation, should they have TAVR and then a staged catheter lab ablation and a Watchman, or should they have concomitant AVR and cryomaze ablation, or the standard Cox-Maze 3 that Dr. Zaire has expertise in? Again, these are issues that should be brought up and let the patient decide. Patients with small aortic root, this is certainly a challenging thing. And I think the consensus committee has addressed it pretty well. They say that should have TAVR unless you're putting in a less than 23 millimeter valve, because the prospective follow-up data shows that's sort of the inflection point where the patient prosthesis mismatch goes up significantly in the TAVR patients. Low-risk patients should be considered for surgery in the hands of an expert surgeon like Dr. Zaire, who has extensive experience with aortic root reconstructions, and the patient should undergo an AVR with a root enlargement or a full aortic root. Patients who've had previous aortic valve replacement, and again, it depends on what is the previous prosthesis size. I know there has been a lot of excitement about cracking the valve open and implanting a higher size. But I think in my mind, if the prior prosthesis is 25 millimeters and bigger, TAVR is absolutely safe. If it's 23 and below, you're running into murkier waters, especially in a low-risk patient, STS less than 5%, who could have a pretty safe surgery. Patients who are awaiting AVR with an underlying malignant condition, fair enough, should have TAVR. Why subject them to a longer recovery with a surgical AVR? Those with coexisting aortic regurgitation should not have TAVR, or it's a predominantly regurgitant lesion. Those with infective endocarditis should be dealt with surgical aortic valve replacement. Multiple aortic valve replacement, aortic mitral, aortic tricuspid combinations. Yes, the technology exists to address mitral, tricuspid, aortic, all with percutaneous therapies. But again, it's the risk-benefit ratio. What are the long-term outcomes? Will the patient survive the surgery to benefit from the long-term outcomes that accrue with surgical AVR? Is a decision that a surgeon should make that case to the patient. An interventional cardiologist should make the case to the patient, and then let the patient decide. And finally, the advantage of transcatheter aortic valve replacement over surgical aortic valve replacement is only if it's being done by transfemoral route. If you're doing a mini thoracotomy and doing a LV apical approach for TAVR, or we're doing a subclavian access, non-femoral access TAVR thus far has not been shown to be better than surgical aortic valve replacement. So I think heart-term approach is paramount, as we will be dealing with these low and intermediate risk patients. We should pay due attention to the patient characteristics. Age less than 50 years, let's talk mechanical valve. Let us counsel them to live with Coumadin home INR monitoring. Not a bad choice. Valves like Onyx valves can be managed with a much lower INR range. Those with 50 to 60, you could swing either way. There are papers that will show that bioprosthetic valve is non-inferior than mechanical valve in that range. And then the corollary gets extended. So if surgical valve is non-inferior to mechanical valve in terms of survival, why not TAVR? Be very wary of this creep, because we don't have the data to make that logical extension safely. And those above 65, fair enough. I think tissue valve is definitely way to go, unless any anatomical considerations. Anatomy, the anatomy of the aorta. Is it a stovepipe, narrow?
Kaushik, can I interrupt just
Please.
on that first bullet point?
Yeah.
Because I think we should spend a couple minutes talking a little bit about age.
Yes.
And I just want to mention that, that we know that there's a few caveats here that maybe not all of the people who view this presentation are aware of. And that is tissue valves do not last as long in young patients as old patients.
Yes.
So when you look at most of the literature for tissue valves, since it generally has been placed in a more elderly patient, it's very common to see lack of structural deterioration headed out all the way to 10 to 15 years. Like if you put a tissue valve in a 70, 75-year-old, pretty good chance it's going to last their lifetime. But we also know from vast amounts of experience over the years that if you put tissue valves for various reasons in young patients, and one of the classic age groups is women of childbearing years that want to have a tissue valve placed because they want to have children and don't want to be concomitant. We are well aware that those valves frequently deteriorate between 5 and 10 years. So we have to be a little bit careful when we look at the partner data and we say, great, a TAVR has superiority or equipoise at 2 years, that we keep in mind if we start putting the TAVR valves in patients that are in their 50s, which is a tissue valve, and because it's the same construct of the surgical tissue valves, there's no reason to suspect that it's going to last longer than 5 to 10 years in those young patients. So I think we have to be pretty clear that we understand that 2-year data of the partner trial is not going to be 10-year data, because at 10 years, we're going to start to see structural valve deterioration. And now you have to decide, you have set the patient on the pathway for a reoperation at age 60 if their initial operation is at 50. And that brings a whole nother situation into the age thing. So when you say age less than 50, I rarely put a tissue valve in anybody who's younger than 60, even in the current era with the Onyx valve being available. In fact, I tell them it would be foolhardy to put a tissue valve in them when they're that young, because they are going to need another procedure before they get to, as they get older. And so I would like the best chance of a more durable result. And I think sometimes that gets lost in the shuffle here.
Yeah, I think you bring a very very apt point, and those reoperative considerations, like patients less than 65, and it's a small aortic root. So even if, say, TAVR, patient wants TAVR, and you're putting in a 23 or a 25, so next TAVR is going to be smaller than that, and those issues should be brought up, that it's not that it's going to be another easy bailout with a TAVR and TAVR. You're going to likely to require a surgical valve replacement the next time, and the mortality will be way higher than if we do
pretty frequent.
the other way around.
It's pretty frequent as these patients come to us that they have been told by outside sources that this TAVR valve is going to last 15 years.
Yeah.
There's no data for that.
And there's no data, and the important point is there's no data, and it would be unrealistic that is true in a 50-year-old.
Yeah.
Because it's unrealistic to expect that TAVR valve is going to be more durable than, say, a Paramount valve, Edwards valve that's been around for 25 years. And we know the durability of that, and we know it's not that in a young patient.
Totally agree. Completely.
That's a very important conversation with from cardiologists and primary care and others about the durability. I think this is the Achilles heel for TAVR. We have 10 years. We have up to 10 years, but durability is 50% of the German registry. And again, the reason why the TAVR started an extremely high-risk surgical cohort who did not live long enough to see if these valves are durable or not. there's an argument on the other side saying there's a new iteration of these valves that are durable. Okay, no problem, but these newer valves are like 3 years old or 4 years old.
Yeah, but
Have 10 or 15
Chadi,
years.
that's a foolhardy argument because we know that there has never, ever been a tissue valve that's produced that is more durable, that's more durable. The longest tissue valve in the history of the world so far is 22 years, as far as I recall, the last one published.
True.
And we know that structural deterioration happens in nearly all patients, starts to happen prior to 15 years. So for anybody to say that there are now more durable TAVR valves that are going to be longer than that is very unlikely.
True. And in the low risk cohort, the only available data that we have now is from the Notion trial. This what that was done in the low risk cohort in the Scandinavian countries. And that trial is reporting 15% structural deterioration at 7 years. So it will come to about the same 15 to 30% at 10 years, which is what we see normally in the structure in the surgical series that are out there. So a very important discussion to lay bare, to make the patients understand as they're choosing their therapies. Concomitant pathology, patients with coronary artery disease, those with diabetes, those with concomitant aortic aneurysms, history of AFib with other valvular pathologies. Again, a very nuanced discussion that can only be done in a heart team approach with both the cardiologist and the surgeon talking to the patient together. We owe it to our patients to give that nuanced distillation of the current literature. Patients who might, those with low ventricular ejection fractions, who might need future mechanical circulatory supports, future valve interventions, again, something to think about. In a sense, we should strive in the heart team to provide all the information that a patient needs to give an informed consent, free of pressure, with the correct information. Please allow us at the DMC Structural Heart team to help our patients and your patients to make the right decision. Our team's comprised as follows: Dr. Terasaki, myself, and Dr. Zair on the surgical side, Dr. Sohal, Dr. Omar Ali, Dr. Al-Khatib, and Dr. Al-Reyes from our interventional cardiology side, Dr. Khan, Dr. Lieberman, Dr. Blank from the electrophysiology side, Dr. Afonso and Dr. Kotem from cardiovascular imaging, and Dr. Barudka for cardiovascular anesthesia. Should you have any questions pertaining to any of your patients in whom you want these nuances, you can contact either of us. And Heidi Carl is our TAVR coordinator. I have listed her email. Please feel free to reach any of us. We are here to help you and your patients. Thank you for the opportunity to bring this topic out for discussion. I'll hand the mic back to Dr. Al-Reyes and Dr. Zair.
I want to bring up one question, and Kaushik, the issue of concomitant cardiac disease, I think deserves a little bit of a discussion. And in your slide there, when you say true informed consent, I think that one of the most important points there also is free of pressure. And I want to bring up like concomitant disease. For example, it's not the second most common thing that happens in a patient with aortic stenosis is a similar process that happens in the coronary arteries, and that's coronary artery disease or ischemic artery disease. And I think that one of the things that has been responsible for pressure, particularly on the surgeons, is patients that have coronary disease and receive an intervention on their coronary disease without that patient coming to the heart team first, so that the patient arrives having already been stented, and therefore that puts significant pressure on the team to not consider a surgical approach for a patient that may well have benefited. What would your comments on that be, Chadi?
Well, to have the, I mean, I think it starts the problem. I mean, not the problem. The process start upstream is to understand the buzz now, right now, is for TAVR. Like everybody say TAVR, we have to do TAVRs and more. But when this patient comes to a physician, I think we have to put all the options out and then make the specialists and the experts make the best recommendation for the patient, as Dr. Kaushik nicely illustrated, about what are the risk of this patient's anatomical characteristics of the valve, risk factors, comorbidities, age of the patient, and also one important factor is what is his recovery, how it's going to be. If you put all this together, it's not like a black and white option. We pick one versus the other. It's a process, and that's why we plug this patient in a process where he or she get evaluated by experts who has been done this before and have done the surgery, especially multiple times before, and put all this data together and give the final recommendation back to the patient that give them best durability, best outcome, as well as the bottom line, the quickest recovery.
Yeah, I guess my plea is that if an interventionalist does have a patient that they really believe should be a TAVR, I would wish that they would also allow us to agree along with them, as opposed to fixing their coronary disease prior to sending them to the structural heart team. Because when we do finally get the patient that has fresh stents in, then it's kind of already poisoned. The well is kind of poisoned to head the patient for a TAVR, which may well not be the best for that patient.
Absolutely.
Particularly in the setting of maybe having moderate mitral valve regurgitation that we would fix operatively at the same time. So I think that these patients should come to us, unintervened upon, so that we all can make the same choice. I mean, we may well decide that the patient would benefit from coronary intervention and a TAVR approach.
Absolutely. I mean, as you said, these patients should be evaluated not in a staged process, meaning getting a
I
PCI
agree. That's
first,
what I
but
wanted you to
it should
say.
be a one full process and give them the best option. So this way, the anticoagulation, the valve thrombosis that Dr. Kaushik talked about. I want to bring it. I'm going to go back a little bit about the leaflet thrombosis for the TAVR. There was a trial called Galileo trial. This is where they try to empirically start these patients on DOAC compared to aspirin and Plavix alone. And the study and the trial stopped prematurely because there was a lot of bleeding, especially cerebellar bleeding, in the cohort of patients who were on DOACs. And this DSMB has to stop this, the patient safety and board of the study, which goes back to the initial upstream issue, especially in low-risk patients. Why did we at the beginning opted for a TAVR versus SAVR, and now we are seeing this slide there. We certainly in low and intermediate patients, they have a 0% or close to 0% valve thrombosis. So these things, I think we have to put it in perspective. Again, there's some risk of stroke in the surgical cohort, but again, before putting a stent, subject the patient to dual antiplatelet therapy, and then putting a patient on anticoagulation becomes triple therapy. It's becoming more complicated, versus when somebody comes to a CAB agent valves or CAB or two valves, it's become more straightforward.
Yeah, I mean, unfortunately, Kaushik, can you go back to those partner trials slides looking at the 2-year curves? Like right there. Unfortunately, a lot of the surgical problems happens, within the first month or two. Like, for example, rehospitalizations, there's a steep rise there after having surgery, and then the lines are completely flat after that. So we pay a significant price for the perioperative morbidity and mortality. And if you could go back another one to mortality, you see the same thing. You see that the death all occurs initially, and then the lines flat, pretty much flat after that. And so it is of vital importance in surgery that we manage our perioperative morbidity and mortality well, that we do our jobs well, and we give a good surgical outcome. Because the difference, the early difference where TAVR is more superior in the lower and intermediate risk groups is because of that. So that being said, my concerns are, as we follow these series out and we start to get into structural valve deterioration, that we're gonna see the lines diverge. I don't think they're gonna stay the same long term out to 10 years, but that remains to be seen.
No, and I think all we owe to our patients is an honest discussion of these things, and it can only happen in the setting of a structural heart team in an unbiased way, with each of the specialists bringing their perspective. The patient is hearing to both the perspectives without having any preformed notions, and then being allowed time to make their decision free of pressure. As you all can see, there are a whole bunch of these nuances that come through that we as specialists struggle to make up. And a lay patient will struggle even more if we don't present the facts in an easily comprehensible manner, free of our own biases, present the literature the way it exists, and help answer questions for them and help them make the decision.
Yeah, I think we should be able to do an okay job with this. We've had the same conflictual therapies between coronary stenting versus open direct revascularization doing surgery. There's a similar lack of equipoise in certain patient populations that favor surgery fairly strongly. And I think it's just like cardiologists have to be responsible in that situation to say this patient is best directed towards surgery. We have to be responsible to do the same in reverse. And like, for example, last week I saw an 89-year-old woman who has no other comorbidities other than being 89. And she's a little bit frail, but her function is decent. And, that patient, I didn't even really give her the option to consider surgery. I said, ma'am, you would be far better suited with a TAVR approach at your age and with the results as we see them.
Yep.
And so I think it's the same. I think the same thing. I think we have to be really careful with the slippery slope of the 50-year-old patient with straightforward aortic valve stenosis. I think it's pretty clear at that stage that the best algorithm for long-term durability is a surgical approach and likely a mechanical valve in that patient. And the literature, I believe, supports my opinion. And I think that while it's okay to have randomized studies to look at this when there's truly a true clinical question, I think that in that specific group, there's not a true clinical question yet.
Yeah, I mean, in that age group, the only confusion, if I may add, has been brought over by Dr. Adams's group with their publication from the New York Registry data. Joe Chickpea was the lead author for that paper, looking at the aortic valves. And in the current age, the Edinburgh trial established the age cutoff of 65 that you and I were trained as we came up. That less than 65, preferably mechanical because of longer lifespan, and more than 65 tissue. But this New York registry analysis paper showed that in the current age, 55 seems to be the cutoff. Below 55, patients are better served with mechanical. Above 55, whether you put a mechanical or bioprosthetic, there is not a big difference. And that seems to be the main paper that gets cited every time when they're talking about TAVR, because if you're putting bioprosthesis, why not TAVR? That's.
Yeah, no, I hear you, but then, there's still conflictual literature because Joe Wu at Stanford also looked at that question recently and still came up with a 65 age for an aortic position. and suggested that maybe we should drop it as low as 60
Yeah.
and 55, whereas the mitral, it should still stay there as what at 65 as well. So I'm, I'm on a fence about it, but like I always say, no one wants their chest open.
Yeah.
So if there's any way to do something with equipoise without getting your chest open, every patient's going to choose that route.
Yep.
So I think that it's fair that I think that we have to take hard looks at the literature as the literature changes, and we be willing to change our minds as to what the appropriate therapy, but that's also true for cardiology, just as it is for surgery.
True. And most importantly, I think I wanted to place that 12% mortality figure, real hand from very experienced group, University of Michigan and Columbia, for TAVR patients requiring a re-replacement for valves, which is...
There's also registry data from the Europeans that, of course, like you alluded to, most of these redos were the TAVR was done in a high-risk patient initially. So those patients are going to have higher morbidity and mortality. But I've had limited experience with removal of TAVR valves, but I've had some. The SAPIEN valve is much easier. You can cut it with a Mayo scissors, and so you can take it out in pieces. But the core valve is quite difficult. Every single pod adheres to that aortic root because the construct rides higher than the aortic root all the way into the proximal ascending aorta. And because it's nitinol, you have to soften it up, believe it or not, by making it cold. So you have to put little chips of ice down there, drip cold saline on it, and one by one pry the prongs out of the side of the aorta. And every single prong you pull away that's adherent to the wall of the aorta, you're worried you're going to tear the root and end up with a root replacement.
Yeah.
So they're not easy. They're not easy to get out, and it's clearly different than just a straightforward aortic valve replacement. Now, fortunately, the two core valves that I have removed, I've been able to save the root and just put a regular tissue valve in their place. But I know that that it takes it's tough surgery, these re-ops. So like I always say, it's always best to try to figure out a scenario by which you make that intervention a lifetime intervention as best we can.
Yep, agreed. Totally agreed.
Well, thank you so much.
We need to take.
Yeah, I mean, there's a couple of comments from the webinar, but we have been getting some feedback, great feedback about the webinar. But I just want to put the plug there for the upcoming webinar. We're going to have a PFO closure webinar as well as a preventive cardiology webinar by Dr. Marianne Mukano, as well as we're going to have a series of electrophysiology as well from Dr. Khan. And we're going to come back to surgery with Dr. Terasaki to talk about aortic dissection and aortic dilatation, aneurysms, and when to refer these patients for surgery. I would like to thank Dr. Mendel for your excellent presentation. It was very short, brief, and to the point, practical. That's going to help a lot of practitioners out there when to refer the patient and what options they have right now. Especially in 2021, we have multiple options, getting a little bit confusing, and you show them the way how you characterize the patients and where to send for help for patient with aortic valve disease, aortic stenosis specifically, as well as aortic regurgitation. And thank you, Dr. Zair, for your time and participation. Always a pleasure to have you as a lead discussant on these panels. With that,
Chadi, I enjoy the controversy about it all. And I think at the end of the day, all of these discussions, the most important point is we all come to some kind of a consensus about what's best for our patients. And the other important point that we notice with all this is it's a moving target as we learn more and more and more.
Yeah.
And we have to reinvent our ideas from time to time.
Yep.
The question from Akshay Kumar, he's asking about should cerebral protection devices be used in all patients undergoing TAVR? Routine use of is not yet incorporated into the guidelines, but in the most recent trial called Reflect trial, also they showed there was capture material in 5 9.5% of the times, they were capturing material that can cause neurological deficit. But when they looked into clinical neurological manifestation of these strokes, there was no difference. So right now, still the evidence out there is not solid. It does capture material, but does not translate into a clinical manifestation of a stroke. So having the question, all patient is no, it shouldn't be.
So true.
This has been looked at very close. This has been looked at also on the surgical side. There are two very large studies.
Yes.
Multi-million-dollar studies looking at ways to capture debris during routine heart surgery, because we know we stir it up too when we cut the valves out, maybe even more than placing a TAVR. And while there was debris caught, both studies showed no clinical difference in the two groups. And because of the expense and the sophistication of the procedures, it's pretty much those trials were 10 years ago, 15 years ago, and that is not part of our repertoire at this point either.
True. And I would just want to bring one point to this, add one point to this discussion, that question will be relevant for strokes that are happening within 30 days of your procedure. But strokes that are happening 6 months, 1 year, 2 years are not related to any cerebral protection device or any change in your technology. That's related to the native disease of the patient, how aggressively you're addressing concomitant AFib, what's happening to the valve thrombosis, and the clots that are forming within the valves. So we have to be mindful to try and dissect those two stroke timeframes. Within 30 days, yes, maybe this technology may have an impact, but beyond that, this technology will have no impact on the ongoing stroke rates. And as you can see from the Partner 3 trial, the stroke rates in the sAVR group didn't go up as much compared to the TAVR group, which crept up steadily to go meet the surgical stroke rates. So just be mindful of that as you think about those issues.
Dr. Zair, there's a question coming directly to you from Dr. Hussein Mahmoud. He's saying, this question is, Dr. Zair, based on the mortality data at 2 years from the Partners trial, do you think that patient with sAVR will have less death at 5 years or 10 years as compared to TAVR group? Meaning, if you keep following them for 5 and 10 years, you think the line will cross favoring sAVR?
I think the lines are going to cross because of structural deterioration. And then all that entails from structural deterioration. Are we still on, Chadi?
Yes, we are.
Yeah. I think that's when those lines will cross. And they're already effectively the same. You know, we'll see them cross probably at 3 years, 4 years. And I think they're going to cross because there's about 25% perivalvular leak. We all know perivalvular leaks get more, they don't get less. And so patients with perivalvular leak will end up with some heart failure. So there'll be a few heart failure patients in that group. So I'm pretty sure those lines are going to cross in the Partner trial in the next year or two. That would just be my guess.
Yeah.
You know, there's a saying in surgery that better a pacemaker than a perivalvular leak. In other words, get your stitches in there firm. And if you end up with a pacemaker because you got your stitches in too firmly into the conduction bundle, that's still better than a perivalvular leak.
Absolutely.
So perivalvular leaks are going to be problematic with this technology if you leave them. And when you see a perivalvular leak rate of 25% in the series, I think those down the road will become problematic at 5, 6, 7, 8, 10 years. Then in 10 years, you're going to start to see structural valve deterioration. So I think the lines are going to cross. I don't know when, but I would say in another year or two. That's why I say be very careful counseling your patients that it's the best approach, particularly the young patients with today's particular valves on the market, because we have yet to have a tissue valve that's going to go a patient's lifetime.
Yeah. Young, low-risk patient. Those are the two things. Young, low-risk patients. Please, please.
We have a plea here from Dr. Zair and Dr. Mandel. And as Dr. Zair said, he's going to see patient. Also, he's going to say, you know what, this is a TAVR candidate. Same thing for Dr. Mandel, because they look at the patient as a total, not just as a valve only. It's about it's a full cohort, a full assessment of the patient by the time they reach to the heart team. So we are up to the hour now, and a few minutes late after that. Thank you so much again for tuning in, for all the people who stayed with us throughout the program. Please stay tuned again for the upcoming program next month on the last Thursday of the month from 12 to 1, DMC Medical Group Heart to Heart webinar. Thank you, Dr. Mandel. Thank you, Dr. Zair.
Appreciate it.
Thank you. Thank you.
I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.